All right, everyone. Welcome to our lecture tonight. We're going to go ahead and get into the shock chapter. I'm going to go ahead and post this one online for you as well so you guys can kind of keep up. Maybe on stuff we didn't cover in depth in class. Maybe just something you want to go back and take a peek at. But we're going to go ahead and dive right into the different kinds of shock and how these affect perfusion throughout the body and kind of some of what we'll do to treat these particular conditions. So let's go ahead and get right into it. So categories of shock you definitely need to be familiar with. We have hypovolemic shock. And under hypovolemic shock, we're talking here about blood loss, so hemorrhaging, or we're talking about fluid volume loss, so we're talking about being severely dehydrated. Then we have cardiogenic shock, and now we're talking about acute myocardial infarction or any other dysfunction of the cardiac muscle tissues or electric system. One that's not listed here, and I'm kind of surprised, and that's obstructive shock. And while it may not go too much into it in the slides, if you ever see the term obstructive shock, think that there is physically something in the way. And when we talk about obstructive shock, you're talking about stuff like pulmonary embolus, you're talking about occlusions in blood vessels, clots, etc. So it's a little bit different. It definitely goes hand in hand with cardiogenic, different causation though. Distributive is also known as vasogenic shock. And under distributive shock, we have 4 subcategories, and they are anaphylactic shock, septic shock, neurogenic shock, and psychogenic shock. Psychogenic we don't talk about too much, but we definitely are going to dabble a little bit into the anaphylactic and septic shock realms, maybe even discuss just briefly neurogenic shock. So let's go ahead and get started. Okay. I will say get familiar with, once again, a lot of your fluid volume expanders. Get familiar with albumin, its functionality, and as well as Hespan and its functionality. Whenever we have patients that are in that hypovolemic shock due to hemorrhage, we're going to go ahead and examine blood products such as PRBCs, platelets, plasma, cryo, etc. Vasoactive agents we're going to be talking about here is vasopressin. You'll notice that when you go into the ICU or the ER, you may actually see 2 separate sets of dosing for vasopressin, and that's due to the fact that vasopressin actually has a GI bleed protocol and has a vasopressor property protocol, and they are actually treated different max dose, different concentrations. So we'll talk about that briefly, and again, you'll probably see it in the ER, ICU. We will talk about dobutamine, norepinephrine, phenylephrine, also known as neosynephrine. We'll talk about nitroprusside. There's 2 more here that we don't have on the list, and that's dopamine, the bigger brother to dobutamine, so to speak. They are not the exact same, but the little brother to norepinephrine. Okay, not that they do all the same job, the exact same. They do very similar jobs in similar capacities. And then we're also going to talk about epinephrine. Okay, and epinephrine's not here, but it's the most powerful of all vasoconstrictors. It is our last-ditch effort if a patient is having systolic blood pressure issues, some hypotension, and it's severe, and we've already maxed out our depressors, we would step into the realms of direct epinephrine. So we'll talk about that more. Definitely going to be talking about antibiotics, antivirals, antifungals as it relates to septic shock. So first we need to start off, we need to know what shock is. Okay, so what shock really is any obstructive condition, any interferent condition that prevents us from perfusing the tissues adequately. And that's the key there. Inadequate tissue perfusion is shock. Okay, the reason for the impaired perfusion can vary. We have a lot of variety here. It could be the pump itself, the circulatory system itself, the amount of volume we have to fill that circulatory system, or potentially even dilation of that circulation system. Because again, if your blood vessels dilate too much, you actually don't have enough volume to even push through them. We have no blood return to the heart and limited perfusion to the tissues. So what does inadequate tissue perfusion or shock result in? We're going to be in a hypoxic state typically. And not just hypoxic like in one location. Typically, we're talking system-wide. The entire body is affected by this. Widespread impairment of cellular metabolism. And one thing to consider is when we go into a state of hypoxia, and you need to remember this, definitely for testing purposes, our body consumes water, or H2O, oxygen, O2, and glucose, C6H12O6. It consumes those 3 things in the mitochondria, tosses them through the Krebs cycle, and the short of it, it creates adenosine triphosphate. Okay, so adenosine triphosphate is the main functional energy source for the body. And not that we don't have others, but it's the most efficient. Okay, it's the best bang for your buck. You're going to get your best fuel mileage, so to speak, in the cell out of ATP. And once again, that's adenosine triphosphate. Okay. Adenosine triphosphate can only be created in the mitochondria in a state where we have oxygen available. Okay. And then we would call, when we have oxygen available and we're creating ATP, we call that aerobic metabolism. Okay. When we go into shock, and now I have hypoperfusion states throughout the body and the tissues and the cells, I go into hypoxia, and eventually the cells become so oxygen deprived, they realize, hey guys, like we're running out of oxygen, but I still need to make energy. What do we do? So what they're going to go ahead and do is they're going to transition into a state of anaerobic metabolism, and that's obviously without oxygen. Okay. So anaerobic metabolism is what we're going to transition into, and we're no longer going to be making ATP. We're going to be making ADP, adenosine diphosphate. And adenosine diphosphate would be the equivalent of an incredibly dirty, nasty, mucky, grimy fuel that does not burn well. It's very inefficient, not a good bang for your buck. And when I say inefficient, I mean less than 20% as efficient as ATP. It's pretty bad. Cellular impairment, tissue damage, organ dysfunction. So what you need to know here is anytime cells become hypoxic, we risk cellular death. When cellular death becomes widespread throughout the body, and I've talked about this and will continue to talk about this in other chapters. You'll see it again in the neuro chapter when we talk about brain deaths, like neuronal brain death, and how those cells that are dying impact the cells next to them by bringing in factors such as prostaglandins, bradykinin, and cytokines that create inflammation in the area surrounding the tissue. The more a tissue swells, the more the capillary flow is impaired, the more the cells in that affected area are in a hypoxic or a decreased oxygenation state. The problem with shock is if we have this throughout, say, your whole body, okay, I have deoxygenation, hypoxia throughout the entire body, cells are deprived, and then my cells even reach the point where they start dying. You can have widespread cell death resulting in mass release of bradykinin, cytokines, and prostaglandins, to name a few components, resulting in widespread reactions and edematous tissues that will develop just about everywhere because of how damaged the tissues are. Okay, when tissues inside organs start swelling, they impair flow to organs even further, and eventually the organs start. You go into what's called multi-organ dysfunction, and that's a whole another ball of wax we'll talk about. Okay. And then essentially what's going to happen is if we don't intervene, if we don't stop the shock state from happening, death will occur if left unintervened. So big point there. Classifications of shock: hypovolemic, volume, cardiogenic, pump, distributive, falls under blood vessel problem. Okay. I've already mentioned these. Initial stages. You must know the stages of shock. I'm going to make it real simple for you. There's the initial stage. The other term for initial stage is going to be the impending shock onset. What this is your body perceiving the incoming shock. Okay. And a lot of people get stuck on the fact they think, oh, a shock is only medical, only trauma, only what. So really, we're not talking about shock. When I say impending shock, it means your body is getting ready to fight back. When your body perceives a threat, whether it's medical in nature, traumatic in nature, whether it's external stimulus, such as, oh, hey, look, a bear, rawr. Okay, and the bear's like, you look like a tasty treat. And then your brain's like, you should probably run away. So your sympathetic nervous system activates, okay, and that's that early onset of resistance to shock. Okay, that's us fighting back. Then we have the first official stage of shock called compensated shock. And this is our body going full-blown reaction, sympathetic nervous system, neural systems are intact, hormones are intact and promoting fight back or flight, fight or flight, SNS, sympathetic nervous system response. And then we have chemical support from the body as well in the form of epinephrine, amongst other things. Really quickly, and it doesn't talk about it, and I don't like that. So if I ever ask you, what's the first stage of shock? I expect to hear, not initial stage, I hear compensated. Initial stage just means onset of early symptoms, but most patients in this stage are asymptomatic, hence why it's not categorized as a stage. The first stage of shock is compensated shock. The second stage of shock is decompensated shock. The third stage of shock, also called as refractory, is irreversible shock. Okay, I'm actually really surprised because you see an A and a B and a D, and I'm 99% sure there's a C. They call C the progressive stage, but really what it is the decompensated stage. Okay, so if compensatory mechanisms are failing in decomp, then the assumption can be made that in compensatory shock, you're fighting back. We have, and if I asked you to list these, it'd be simple as this, like SNS activation, increased heart rate, vasoconstriction, resulting in increased blood pressure initially. I have bronchodilation, so I can get more oxygen into my lungs. I will transversely have a increased respiratory rate to get more oxygen to my tissues. My heart's going to pump harder and faster. We already talked about that. Your pupils, believe it or not, are actually going to dilate to take in more light so you can see and perceive your surroundings. Your senses will be heightened: touch, feel, taste, smell, etc., hearing. And your body is ready to fight back. And in the process of doing all this, your core actually contracts down so hard that actually also pulls a lot of the blood back from the periphery that is currently in, like, say, your GI tissues. It also kind of pulls blood away from the kidneys a little bit and shunts it back to the core because it realizes, hey, you really need more blood. You need more oxygen carrying capacity. You need more CO2 carrying capacity and more nutrient capacity. So that's the compensated stage. If I ever ask you for decomp shock, and you can call it progressive, that's fine. Okay. But all those things that I just listed begin to fail. Okay. So, and the reason it's failing, and think about it, then let's throw out, let's say the bear in the woods. Okay, he somehow catches you because, well, let's face it, you're like me, you're probably slow. The bear catches you, slashes you, and now you're bleeding all over the place. Okay, so it's still, sympathetic nervous system is active. So, but here's the thing. If the pump itself doesn't work, if I'm running out of volume, if there's something physically obstructing the movement of blood, or if the vessels are dilating, the question is, can I keep feeding the heart and the lungs, the parts of my body currently working overtime to fight back? Can I continue feeding them at adequate rates, oxygen and glucose and nutrients, all while removing wastes from these areas? And the answer is yes. For a little while I can compensate, called compensated shock. And then after a while, like in most other muscles in your body, because when you work out a muscle, you build up lactic acid and other wastes. What ends up happening is you have lactic acid build up around the muscle. Okay. So the problem is now we're building up lactic acid and waste faster than I can remove it. I start going into a state of hypoxia because I'm not providing as much oxygen to the tissues, but I'm asking the tissues, again, intercostals, diaphragm, heart, lungs, I'm asking the tissues to perform more, to contract harder, beat more. I'm asking for increased contractility, conductility. I'm asking for bronchodilation. I'm asking for a faster respiratory rate. At the end of the day, I can fight back, but I consume substantially more energy in a compensated shock phase, and you can only last so long in that phase. Okay. Once your body is running out of resources, oxygen, sugar, water, etc., or the muscles are extremely fatigued and I cannot remove waste as fast as I can build it, you start going into that decompensatory state of shock, stage 2. And what happens is now we see decreased perfusion begin throughout the body: brain, heart, lungs, kidney, GI, liver, pancreas, vascular changes, and hematologic alterations. Okay, so, and then the cells, as you graduate through this phase further out of decomp, I'm still fighting, but it's like watching a boxing match, really. First couple rounds comes out, just banging, just boom, 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 boom. We're fighting, we're blocking, we're bobbing, we're weaving. Okay, we're really getting at it. All right, and your body's like, "Yeah, I got a chance." That's what you're saying, is it's a chance. And then what happens is we get into 7 out of 10 rounds, and we're getting into the back half of that fight, and we're like, "Whew, a little bit tired." And your body's no different. And your muscles, especially that we're asking to work harder, are no different. So they get a little bit tired, they get worn out, and then you can kind of see that continual, gradual decline until we reach a state of what's called, I already passed it, refractory or irreversible shock. In this state, we are in anaerobic metabolism. I am creating ADP. I am building up toxins and waste throughout the entire body. I am not filtering out pretty much anything. My organs don't even have enough blood flow to really continue to do their job. And when you get into late stage decomp shock heading into irreversible, not only this is where we're going to see our nausea, vomiting, altered level of consciousness, impaired responses. Patient will be alert and verbal. Will more than likely head into that verbal, painful or unresponsive territory. They're no longer going to have the cognitive capacity, the mental capacity that they need to continue fighting back. If we do not intervene in the compensated or decomp phases of shock, the patient will absolutely die. If they step into full-blown irreversible shock with multi-systems organ failure, death is inevitable, and I said it earlier because the cells throughout the entire body are widespread dying fast. Okay? So, here, just if you ever need to go back and look at your hypoperfusion and shock, I would go back and take a peek at this. It just kind of talks about a little what's going on. I will point out really quick, and we don't talk about it probably enough, is the fibrinolysis and the DIC conditions that occur in the hematologic systems. And these are more common when a patient is fighting back in the medical/hospital setting. Okay, I'm not talking about fighting a bear. You don't suddenly just go into fibrinolysis and bam, I'm either making clots or breaking clots. DIC is a more progressive evolution of the shock pattern and typically takes longer onset. Big one that we saw actually, ironically, during COVID was DIC and fibrinolysis. What we were seeing, and for those that don't know, is disseminated intravascular coagulation, is DIC. We were seeing patients that had, for all this time, we'd had them on Lovenox, had them on thinners. We were fighting back. Their bodies were fighting the infection, not necessarily winning the fight, but they were kind of hanging on, and then they started losing the battle. And as they started losing that battle, we stepped well into the realm of hypoperfusion to vital organs that control hematologic functions. And what ended up happening is you see this widespread cell death, a massive cytokine storm throughout the entire body, which would passively lead to conditions of DIC. You would see them all of a sudden start just bleeding from just about everywhere. And I mean everywhere. Central lines. I've seen Foley's bleed for no reason. And I don't mean something happened, we moved them, something changed. I mean, no, they just start bleeding. You almost literally lose the ability to clot. And then on the backside, we go into a state of, in DIC, we go into a state of hyperclot formation. And then all of a sudden, I have DVTs all over the place. I'm throwing clots. I have strokes. I have MIs. I'm having PEs. I have a pneumo over here. The list just kept going, and it just kept getting worse and worse. So DIC is a big consideration for shock, but more so in patients with long-term conditions, mostly medical in nature or septic. Hypovolemic shock, decreased volume due to loss of blood or loss of fluid. Okay, I'd like to remind you guys, and people are like, oh, you got dehydrated. Well, not entirely. That's partially true. There are conditions, and especially with heart failure, I'd like to remind you, especially severe peripheral edema, pitting edema, +3, +4, pitting edema, lower upper extremities, when your fluid leaves your blood vessels and goes places it does not belong, that's called third spacing. Okay, and that is a perfect example of fluid still in your body, but not where it belongs in your blood vessels. All that fluid shifting out of your blood vessels and into your body, your third space, your tissues, will substantially decrease your pressures, and you will have fluid. Your body will act like it's dehydrated. You become tachycardic, hypotensive, severely dehydrated, decreased urine output, but the fluid is really just stuck in places not accessible by capillaries or blood vessels. So that's something you might want to consider and think about when you're looking at this kind of stuff here. So pathophysiology of hypovolemic shock. We're going to talk about this a little bit more. Sorry about that. Had a little hiccup there. Anyway, so things you wanted to consider back here, though, again, we're talking about either blood loss, fluid loss, and dehydration, or fluid loss in the third space. Anyway, so decreased venous return, we're losing that preload coming in from the vena cava into the right side of the heart. I'm losing the ability to fill the ventricles. I'm losing my stroke volume. We talked about that a little bit in the cardiology aspect of things, hemodynamics. Again, stroke volume, average 60 to 70%. Stroke volume is typically between 65 and 70 mLs per stroke. And I have a decrease in blood pressure and volume out per stroke. Decreased cardiac output, decreased intravascular volume available okay, resulting in inadequate perfusion. I literally don't have enough to pump, is how this slide should read. So, anyway, pathophysiology. Signs and symptoms vary, and that is very true. If we're losing blood versus losing fluid, we have a very different discussion on our hands. So, here's some numbers where you can kind of see, in terms of blood loss in mLs, what happens to our cardiac output. If we lose about 15 to 20%, and by the way, 20 is on the high side for a healthy individual, 15 to 20% of blood loss we can incur, okay, and our heart can contract, we can basically constrict, and that's that, again, SNS activation, fight or flight, compensated shock stage. We can fight back. But after we get past around the 20% mark, we really start stepping into the realm of our cardiac output decreasing due to stroke volume and preload decreasing, both in hand. Again, they hand in hand. Profound shock occurs once we're past that 30% mark. Excuse me. Okay, and then we step into the realm of 40-50% refractory without rapid resuscitation. And you'll end up in a state of irreversible shock with more than 40 to 50% blood loss. I literally don't have enough oxygen carrying capacity to continue in a state of aerobic metabolism, resulting in hypoxia and a lack of oxygen, buildup of lactic acid, and we have a major problem on our hands unless we directly intervene. I really like this picture. It's kind of funny because there's like 7 books that use this picture. It's kind of funny. But anyway, you can already tell, and I'll just give you the background on the picture. I kind of researched it a while back. This gentleman was involved in a traffic collision. He actually had his belt on, but we have a couple different things going on here. Okay. I do have, and by the way, one of the absolute keys of treating anybody in hypovolemic shock, blood loss or otherwise, is having dual, preferably, excuse me, dual 18 gauge large bore IVs. That's a big one. Or if I can't have 2, which is preferable, I'll take at least mandatory 1. But we can look at this patient. We can definitely see he had a seatbelt on, but I also have some other things going on here. If you take a close look at the body, I see some different things. Yes, I do see a Swan-Ganz catheter. That's not what I'm most concerned about. But I do see some distension. And there's an old acronym. It's called TREAD-GHP. And whenever I look at patients that are in potentially internal or external hemorrhaging states, I ask myself, tenderness, rigidity, evisceration, distension, guarding, and hot belly. Okay. What I'm looking for is distension. I'm looking for any discoloration, and I do have some up here a little bit. Okay. Looking for any specific localized swelling. Okay. I would look, and when I palpate, I would be looking for any rigid regions. If there were specific regions that were rigid, I'd be high concern for I almost said destruction of an organ, but the rupture of an organ or potentially blood loss from that organ. Okay. Likewise, we have guarding and hot belly. If you have a place you're touching and it's incredibly hot, one of 2 things: it's infected or blood is underneath the surface there. And then guarding is just the body's natural response, the individual, if they are conscious, awake, and alert, to withdraw from pain or protect their body from pain. But in this picture, you can definitely see he is distended. This is not how he normally looks likely. We have probably internal bleeding somewhere down here. And based on what I'm seeing in him, I can almost guarantee you he came in with no pressures, either severely tachycardic or late stage decomp shock, and stepping into the realm of bradycardia. Shock management, normal volemia. What do we need? Just said it. Large bore IVs, hypotension crystalloids, specifically LRNS. Remember that. We can use volume expanders, specifically 5% albumin, and then we can transfuse PRBCs or blood products entirely. And blood products, plasma, okay, platelets, red blood cells, okay, and we can even use cryo if necessary to encourage clotting in the body. A couple other things to consider, and please remember LR and MS are really big. The albumin, what we're trying to do with the albumin is we're trying to pull back fluid from interstitial and third spaces into the vasculature. That's what we're trying to do, and that's what albumin does. It's a protein. Water has a very high affinity for it, or H2O specifically, and it pulls it back into tissues. Other things we want to do, if it's an external hemorrhage, control it. Internal, it may be a little harder. Get ready for this patient to go to surgery if they have an aggressive internal bleed and they have signs and symptoms of hypovolemic shock, either decomp or comp. A lot of things we're going to go ahead and monitor. If you ever get to watch a patient go into a trauma center, sometimes they will use the SWAN scans. You're going to get, it's standard though, in severe trauma cases, art lines, CDPs right off the bat. They're easy to put in and quick. Then the next would be SWAN GANS catheters. We're going to do strict eyes and O's. I need to know how much you're putting in, or excuse me, how much I'm putting in, how much you're putting out, if any. Foley catheter will go in, and not because you're incontinent. It's going in to monitor strict eyes and O's. Definitely going to be getting CMP, CVCs with differential, LFTs, DIC panels, lactates, chest x-ray, EKGs, and ABGs. We'll talk about those more in a little bit. We gotta perform the cardiac functions for him if he is in a state of hypotension. What I mean by that is if this particular individual is, say coming in and they're already in shock and they're already compensating, and they start decompensating, and all of a sudden I'm hypotensive in the 70s/60s systolic, we're going to go ahead and we're going to give him something that can help him contract harder, increase the heart rate potential just a little bit, but contract harder is the key, increasing output pressures. And that's a big one. By increasing output pressure, we increase stroke volume amount, increasing amount of fluid, blood specifically, amount of blood available to the tissues that we are currently trying to oxygenate. If a patient comes in hypovolemic shock, we are going to treat for acidosis and hypoxia, correct electrolyte abnormalities if any exist, and that's more of a secondary concern. We are concerned, but it's definitely your hemoglobin being 4 is bigger concern than your potassium being 5.2. Okay, we're going to prevent complications. We're going to do ongoing assessment of tissue organ perfusion, vital signs, level of consciousness, dynamics, urine output, cardiorespiratory response, status labs, EKG, ABGs, and etc. Some more. Okay, cardiogenic shock is a different kind of shock, and we're stepping into a different realm now. It results from impaired myocardial contractility, and you can almost always relate these to either left or right heart failure or MI. Okay, but anyway, your stroke volume and cardiac output are severely decreased, and anytime you decrease those two, we end up with a decreased state of perfusion to the peripheral tissues or even the core tissues. This only makes people that are already in an ischemic state that much worse. So people that have a heart attack, for example, step straight into the realms of acute cardiogenic shock. Okay. Causes, just as I said, right and left ventricular failure, or left and right heart failure, massive anterior MI, and I will put an asterisk next to that because anterior MIs are the most common, acute or acute on chronic heart failure, and then we have other ones. We have cardiomyopathies, so we can have stiffening of the cardiac muscle, we can have atrophy of the cardiac muscle, we can have enlargement of the cardiac muscle, valvular dysfunction in any of the 4 common valves, but typically the aortic valve is the most concerning, cardiac tamponade, again, that'd be a shock to the heart, typically not a shock, electrical shock, but like trauma, direct impact causing damage to the heart muscle, and swelling around the outside of the heart. Problem with that is your heart's inside of a sac, and the sac only can expand so far. So much like pneumothorax, hemothorax, or hemopneumothorax, when there's fluid around your heart and that sac reaches capacity, it begins to put pressure back on the heart, crushing the heart, not allowing it to expand and fill in between systole and diastole. We can also have dysrhythmias, which fall under that electrical category, and then we can also have pulmonary embolisms. They fall more under obstructive shock, but again, just be aware of what these are, and we'll go ahead and classify them as cardiogenic shock for testing purposes for now. Pathophys, impairment of either the left ventricular pump, so our left ventricle, or our right ventricle, decreased stroke volume, decreased BP, decreased cardiac output, decreased tissue perfusion, decreased or inadequate systolic emptying, meaning, I may have 100 mLs in the left ventricle, but it's tired and worn out and can't contract the way it needs to. So I'm only getting out 40 mLs per stroke, kind of a problem. Increased left and end and diastolic volume, that's what I just said. LAP, pulmonary venous pressure, and yes, we're going all the way back. Right about here is what really I'm focused on. The rest are just secondary cyclic results of the initial cardiogenic causation of shock. And then what ends up happening is we have a forward failure, and that's what you can break this into right here. Forward failure resulting in a backward failure. That's really what we're saying. And it's a vicious cycle because once both forward and backward failure occur, it doesn't damage, but it makes the heart's job of increasing output almost impossible without support externally. How do we manage it? It's actually pretty easy. Increase the O2, decrease myocardial demand. Okay, there's some different things we can do to do that. Okay, we do like nitro. We like doing morphine. And again, we go back to that. We use the MONA acronym from time to time. So morphine, oxygen, nitro, and aspirin. There's our protocol. Be very cautious with that oxygen, not to create acid imbalances. We're going to improve contractility via inotropes and assure adequate oxygenation and ventilation, meaning my respiratory rate is a big piece here. If you're breathing 30 times a minute and you're in severe pain and it's shallow respirations, it's not adequate. I may be able to put a non-breather mask on you, provide more oxygen, and decrease your state of shock. And if that works, a non-breather, a simple mask, a Venturi mask, and that's adequate enough to offset the amount of oxygen a piece of tissue, heart muscle specifically, needs, then that's fine. If it's not enough and you're maxed out, 15 liters, non-rebreather mask, and their body's still, I need more, then we would step into the realm of considering BiPAP, which is not recommended for cardiogenic shock. Okay. Or in this case, we would consider intubation for cardiac rest, oxygenation, increased myocardial O2, and decreasing the myocardial O2 demand. In the event that it's stentable, we're going to stent it. We've talked about stenting in the past. PCIs or percutaneous interventions are definitely at the forefront of our considerations. Door to needle time is 30 minutes. Door to balloon is 90 minutes. Please remember that. If it's not a candidate for a PCI procedure and there's no contraindications, we might even consider fibrinolytic therapy. The ones in the hospital that you most commonly see is your TNK-ACE, okay, or your TPA, your tissue plasminogen activator. Both are fibrinolytics. They work a little bit differently, but essentially the goal is the same. We are going to go in there and play Fruit Ninja with your blood clots. Not Dilaudid, not fentanyl, morphine, cardioprotective properties. Let's move past that. Let's talk about distributive shock and get into vasogenic shock specifically. Broad category: neurogenic, anaphylactic, septic, and psychogenic shock. So here's our issue here: is all four can be categorized the same. In that, or all four subcategories can categorize the same. In that vasodilation widespread throughout the body occurs, I literally don't even have enough volume to fill the vessels all the way up, and I begin to leak fluid into my tissues out of the bloodstream, third spacing again. And I literally don't even have enough blood to get back to the heart. You're not dehydrated. You didn't lose blood. You just vasodilated so much you don't have enough to fill the blood vessel's entirety. So when your blood vessels contract, blood doesn't really move back to the heart the way it should. So kind of a big deal. Another way of putting it: maldistribution of blood flow. Massive vasodilation due to loss of sympathetics. So let's talk about neurogenic. Neurogenic typically comes into play when we have a spinal cord injury or injury to the CNS somewhere. Most commonly cervical spine down to the thoracic spine. Much past that, you can still have neurogenic shock, but it's not as common. But massive vasodilation, you're going to have an acute or initial spike with your body trying to compensate blood pressure, and then a rapid drop because we literally lost, if depending on what part of the spine we damaged, we lost the ability to vasoconstrict peripheral vessels. That's kind of a big deal. Okay. Here's a perfect example of step off due to cervical injury. And you can even see the spinal cord, brainstem, spinal cord. That's bad. Okay. And when we have a patient in this state, and you can see here that pinching of the spinal cord, I literally lose, and you can essentially it's like a hose. You ever kinked a hose? You kink the hose, it's hard to get water out the other side. Likewise, you kink the spinal cord or put pressure on it, it's hard to get messages through this canal. And you're like, oh, well, it's still there intact? No. Either nothing will get through or barely anything will get through. This is terrible. This is bad. Okay. So what do we get? Massive vasodilation. Venous dilation, substantially decreased preload, substantially decreased ventricular filling, wicked decrease in stroke volume and cardiac output. I'm not getting anything to the tissues. And what's even worse is we have arteriolar dilation, substantially tanks our peripheral vascular resistance. I literally am not returning anything to the heart, and the heart even wants to do its job. It's perfectly fine. It's like, hey, I'm a good pump. Let me pump. I'm not even returning anything to the heart for it to pump. That's the problem with neurogenic shock. We got to treat the cause, and we got to treat it fast. If you can restore vascular tone with medications, we will do so. And this is where vasoconstrictors come into play and volume expanders come into play heavily. If we have extra volume in the periphery, cool, albumin. But that's not usually our treatment here. We're going to go ahead and expand volume, typically in the form of NS or LR. And then we're going to use a vasoconstrictor, typically something like vasopressin or Levophed, depending on the state of the patient and causation. So, fun facts. Stepping into the realm of anaphylactic shock, a different subcategory of distributive shock, we have severe immediate systemic hypersensitivity responses to what is an allergen, also termed antigen. Fun fact and reminder, you are never allergic on your first exposure to any substance or antigen. You are going to be, potentially, on subsequent re-exposures, you will have that reaction / allergic response. So essentially, first response, exposure to antigen, body scans it, attaches the cell. Ooh, don't like that. Next time you come, I'm going to give you one chance. Next time you step in here, man, I'm messing you up. Well, there's one problem. The antigen's attached to your cells, so it's going to mess your cells up. And that's kind of an issue too. So what ends up happening, second and subsequent exposures, all of a sudden antigen's back in the body. Your immune system's like, I told you not to come in here. Your body responds. Massive vasodilation, capillary permeabilities. We're just dumping fluid out of our blood vessels into the tissues. Big problem. Okay. We stimulate the IgE antibodies, and then IgE binds to mast cells and basophils, resulting in an attack on our own body, a cell-mediated response, essentially. Common antigens and big ones, and actually what should be before any of this is not antibiotics, it's foods. A lot of people have food allergies, even my son, and we found out the fun way, he is anaphylactically allergic to eggs. And eggs are in absolutely everything. Excuse me. So, when you're in the hospital, and this is why we harp so hard on like what is this patient's history? What are their allergies? And you'll see people come in and be like, yeah, I'm allergic to oxygen. And you'll stare at them, as you should, because gee golly williker, Batman, I don't think anyone is allergic to oxygen because you're currently breathing it. What they may be allergic to, and here's something I've actually heard, and I encourage you guys to explore a little bit more about knowledge. If you hear something like that, explore it. Come to find out, they're actually allergic to the adhesive on the tape that was being used to hold the O2 device in place surrounding their nose and mouth, causing a reaction and actually them to break out all over their face, lips, and nose. So, fun fact. But investigate. Ask, what kind of reaction did you have when you ate, whatever it is they say they're allergic to? What do you have? When you have, if it's a medication, antibiotic, what's your reaction? I need to know. Are you allergic to contrast, iodine? Are you allergic to shellfish, seafoods, avocados, latex? What is the reaction that you have? What is the severity? So this is kind of a little breakdown of what it would look like. But essentially, antigen, antibody, ICU, no ICU, no ICU, no ICU. Hey, look, an ICU joke. Anyway, antigen, antibody reaction, release of vasoactive substances, specifically inflammatory responses, prostaglandins and bradykinins, substantial widespread vasodilation. And by the way, we haven't even talked on the fact edema, angioedema, hives, creating states of cyanosis, increased secretion in the bronchi and bronchioles into the lower airway, constriction of the airway. Essentially, we're looking for an agent to immediately get rid of this. Okay, there's a couple ways we can attack this, and in less emergent cases, mild to moderate cases of allergic response, we would step into the realm of antihistamines or H1, H2 blockers and bronchodilators. In more moderate to severe cases, now our first response to any severe case, absolutely right up front, is epi. Our secondary response could potentially be steroids along with antihistamines and bronchodilators, but there's a consideration they may not be active right away or bioavailable due to decreased peripheral circulation. You hear a lot about EpiPens in the field, especially in EMS. You hear about people using EpiPens, and typically the adult dose is 0.3 milligrams, whereas the pediatric dose is 0.15 milligrams. Then it's via autoinjector into the vastus lateralis in the thigh. which is great because epi works wonders. There's the two desired effects that we're after with epinephrine if we're administering it for anaphylaxis, and that's vasoconstriction and bronchodilation. Those are our two desired effects in this particular instance. There's only one problem. Epinephrine has an incredibly short half-life depending on how healthy you are and how well you're clearing it. It could be as short as 4 to 6 minutes in terms of half-life, sometimes in some cases even shorter. And then, so what you can have is cessation of advancement or even cessation of symptomology consistent with anaphylaxis. And then all of a sudden, you turn around 15, 20 minutes later, and it's all coming back. And you require secondary dosing. So in the hospital, we have a very different setup. I can give IM epi if necessary. I can give IV epinephrine if necessary. But in the field setting, it's a little bit different. And EMS does not just have free reign, typically, to give as much epi as they want. They can, but they typically have to go through a doctor's orders. They have to call base and get orders for extra epinephrine doses in the event of secondary, tertiary, or quaternary reoccurrences. So something to consider. But anyway, when I ask you what kind of meds I want, you better be able to tell me. Epinephrine, antihistamine, or H1, H2 blockers, bronchodilators, and steroids. That's how easy it is. Hey, look, EpiPens. Woo. Let's talk about septic shock. Okay. You going into the ICU is probably one of the most common shocks we see is septic shock. When we talk about septic shock, you can automatically step into the realm of infection because that's exactly what's causing the shock. We have localized infections, and that's no big deal. We can treat those potentially with even PO meds, maybe some creams, depending on the location of the infection. But we have our normal causative microorganisms. I'm not going to go into them in detail, but gram-negative and gram-positive bacteria, okay, atypical bacteria, viruses, fungi that aren't such fungi, and multi-organism sepsis. Yes, that was a dad joke, by the way. Okay. So, but the thing here is we no longer have, if you're in a state of sepsis, we no longer just have a state where we have a localized infection. No, that infection now has moved, proliferated, and we now have infections systemically throughout the body. Okay. And I don't mean the whole body is full of pus. No, what I mean by that is we have components of bacteria or bacteria themselves moving throughout the body, seeking out other host cells. Also, as the bacteria / virus / whatever is in there takes over cells and kills them, those cells begin to widespread release toxins throughout the body, essentially poisoning you from the inside. Big, big, big deal. And then all of a sudden, by the way, it literally is the equivalent of dumping poison directly into your bloodstream. It will kill you very quickly. So then you end up in this multi-organ systems failure because, well, your other cells don't like poison, and it causes cell death elsewhere in the body that originate or is away from the origination of infection. So 50 to 90% mortality prior to advent of intervention. That is 100% correct. One of the keys, and if I ask you what is the key to septic shock treatment? It's early identification of sepsis. That's absolute key. And causation. UTI, Klebsiella, we talking pneumonia. What do we have? And you need to identify it often and early. Okay, 1 out of every 23 hospital admissions accounts for nearly half all hospital deaths. Sepsis, yes, crazy, I know, accounts for more than 20 million in U.S. hospital costs, and that's a over decade-old number. It's probably actually a lot higher. I'd really hate to see what this number looked like during COVID. So what happens during shock? Okay. Systemic response to infection. Localized, not a problem. Okay. Infection starting to take over tissue, bradykinin release. Body's overreaction even further. Endotoxins and exotoxins trigger full-blown immune response. Vasoactive substances. Hey, almost sounds like anaphylaxis. It is. It's almost like anaphylaxis. Almost not. It's not anaphylaxis. It's almost. Hemostasis is disrupted, uncontrolled cascade of inflammation, coagulation, and impaired fibrinolysis. You can just literally take coagulation and fibrinolysis, put them together, and congratulations, you have DIC. And it's not, I said it earlier, it's not uncommon for patients with infections and long-term treatment modalities to step into the realm after a long period of fighting with an infection or during an aggressive infection cascade where it steps from controlled to uncontrolled. It's not uncommon to step into the realms of DIC at that point. Massive vasodilation, capillary permeability, maldistribution of blood. Once again, we have warm shock versus cold shock. Warm shock is often called the early stages of shock, whereas cold shock is the late stages of septic shock. You want to catch them while they're right here. This is a massive deal. I can't express this enough to you. Warm shock is just how it sounds. Hot, flushed, and moist. Running a fever, tachycardic, a little bit warm. Something's going on. Something's attacking me. Let's get after it early. Hey, let's go do some cultures. What kind of cultures? I don't know. Let's do blood cultures. Do you have a central line? Okay, let's culture the center. And by the way, the culture in the central line is usually the last-ditch effort after we've exhausted blood cultures, urine cultures, sputum samples, or smears. We're looking for all the common causes. And if you've been caring for your central line properly, you shouldn't have a CLABSI or a CAUTI from your Foley or your central line. Same can be said for arterial lines, Swan-Ganz catheters, and any kind of other devices we might use to penetrate the body. Anyway, warm shock, cardiac output, hyperdynamic. We're fighting back. We're doing it. We're good. We're good. We're good. We are not good. We are no longer good. We are in what's known as a hypodynamic state. So what are we after? We're looking at temperature. We're looking at systemic inflammatory response syndrome, or SIRS. Okay, we're looking at heart rate greater than 90, just mentioned a minute ago. Respiratory drive greater than 20. Why? Acid build up, lack of oxygen. We're going to try and compensate because we're stepping into the realm of metabolic acidosis. White blood cell count above 12,000 or below 4. Because we've exhausted them. Infection, inflammatory response, presence of microorganisms, we already know that. Bacteremia, it's in the blood. Viral bacteria are now inside your bloodstream. That's a massive issue. We don't like that. Sepsis, 2 or more serious criteria are met as a result of an infection. In severe sepsis, organ dysfunction has been introduced into the equation now as well. You must treat this aggressively. I will ask you to know the definition of shock per the ACCP and the SCCM. Hypotension despite adequate fluid resuscitation along with the presence of perfusion abnormalities. I can literally pump you full of 2 gallons, the equivalent of roughly 7.4 liters full of fluid. 7.6? 7.6, sorry. No, 7.4. 7.4 liters full of fluid. I could put you on vasopressors. I could put you on everything. And guess what? It will barely make a difference or barely keep you holding on. We are now in severe septic shock. However, we threw this out. Goodbye. It's changed. We now have the third international consensus definitions for sepsis and shock as of 2015. And these are the standards that we run by. Life-threatening organ dysfunction caused by dysregulated host response to infection. This is our new standard. This is our criteria. And the reason we changed is that not only did it broaden the definition, but it also identified signs and symptoms and presentations of early sepsis or warm sepsis better than our previous definitions. I do want you to know, and I wasn't joking, I still want you to know what this is. I want you to know that this is outdated. We do not use this. That's why I want you to know it. So when you see it and you're like, oh, this is no longer the thing. I want you to know we've moved on to sepsis 3.0. Okay, life-threatening organ dysfunction, dysregulation, host, response to infection. That's how easy it is. Okay. I'm not doing SOFA and QSOFAs because we don't do them. Risk factors. I want a list. I want you to know these. Younger than 1, older than 65, surgical procedure recently, invasive is the key, malnourished, broad-spectrum antibiotics on a frequent basis. It's really bad to be frequently using antibiotics. Chronic illness, multiple comorbidities, compromised immune status, malignancies such as cancer, and status post-transplant or immunosuppressant therapies or drugs, increased number of drug-resistant organisms. I got bad news. I have really bad news. Stepping from the 80s into the 90s, we were like, hey, I hear you sniffling. Would you like some antibiotics? And doctors were handing out antibiotics like absolute candy. The greatest thing since sliced bread. Hey, what's that? Minor inconvenience? A little head cold? Nah, let's go ahead and get rid of it. Fun fact, and it's kind of in their name, antibiotics, bacteria, do not directly treat, damage, or destroy viruses or fungi or parasites. It can help support and suppress bacteria in the body so your body can do its job to fight. But antibiotics by themselves do not directly treat viral, fungal, or parasitic infections. But we were handing out these antibiotics like candy, and they worked. They did the job. They did great. All of a sudden, everybody's like, hey, what's that? Got sniffles? Don't worry. Head over to the equivalent of Dr. Mike's in the 1970s, 80s, and they hand them out to you. And it only got worse for about a 30, 35-year span. And what ended up happening, and we're seeing the results of this now, not now, but we've been seeing it for about a decade. We're seeing these new mutated versions of bacteria that are coming out. And the first one that ever, not first one ever, but one of the first and most common ones we discussed is methicillin-resistant Staphylococcus aureus, or as many of you might know it, MRSA. MRSA, methicillin-resistant Staphylococcus aureus, is a staph infection that is obviously resistant to what? Methicillin. Okay. And so we came out with, we need something aggressive. Well, and there's more that can treat it than just Vanco, but Vanco just seems to work really well on it. So what do? We treat MRSA with vancomycin. And we nuked it. And we're like, hey, we're all high-fiving each other in the lab. Woo, good job, guys. You're great. We're better. We're the better species. Bacteria kind of chuckled, shrugged, and came on about their way. Lo and behold, next one was Versa, VRSA. And guess what? Just how it sounds. Vancomycin-resistant Staphylococcus aureus. Anyhow, enough about that because it actually doesn't stop there. It keeps going. We now have super bugs, we call them, or super bacteria that are almost entirely drug-resistant to every drug known to man, which is why we are currently working on, or have already created, and I'm just simply unaware, antibiotics. We are constantly trying to create new versions to fight common infections that have simply mutated into new versions that are resistant to previous treatments. Big deal. But again, the ones that unfortunately get attacked the hardest are kids, typically in that infant range, and geriatrics above 65, compromised immune status, malignancies, their immune system's already under attack. And it just gets worse for them. Especially, and most people don't know this, the number one population that is killed by infections and sepsis is geriatrics. And it goes, and this is devastating, pneumonia UTI. Pneumonia is the number one septic cause in geriatrics that kills them, and UTIs are number two. How many times have you seen patients come from nursing homes to their own home, neglected, not cared for? They come in for UTI, and you're like, oh, no big deal. And some of you might be sitting here thinking, oh, I've had a UTI before. Or, oh, yeah, my girlfriend or he or she or they or them or whatever had a UTI, and oh, they just got antibiotics. Well, that's fine, but believe it or not, there are actually instances where we now have a bacteria that's been introduced to the urinary tract that is so resistant to so resistant to antibiotics, even as you come in and I give you Vanco, it may not be enough to kill off that bacteria. Not only that, and I'd like to remind you, there's many antibiotics, they're only available in the territories in which they are absorbed. So IV vancomycin is available in your bloodstream and potentially into your tissues. It has a hard time getting into parts of your bladder. So stuff like that, can the capillary beds carry vancomycin to the site where the bacteria are infecting? So stuff like, or not just Vanco, but any antibiotics, stuff you need to consider. Anyway, early signs and symptoms of what we're looking out for: fevers, chills, tachycardia, increase in white band count, eosinophils specifically, or WCs. Signs of poor tissue perfusion, decreased urine output's key. Ooh, I love this one. There's a reason we like strict I's and O's in the ICU. People underplay the value of the renal system. The renal system is one of the most underspoken hero systems of the body. If you see a decrease in urine output, that's an early sign that you have decreased perfusion to the kidneys and decreased cardiac output. We have a problem. Coagulopathies, DIC, elevated lactate levels, and so on. What do? Identify the problem, get control of that infection quick. Sometimes it even requires surgery. Most of the time you're going to come in, all right, cool, you got an infection. Let's do some sampling. Let's do some staining. Let's do some gram stains. Let's go ahead and do some blood. Oh boy, words. I'm skipping words today. Let's do some blood cultures. Good Lord. Anyway, we're going to do blood cultures. We're going to go ahead and identify the kind of bacteria we're fighting because we can do what's called culture and sensitivity, where we actually identify what we're fighting and what it's sensitive to, like what's good against it. Additionally, we can go ahead and do broad spectrum antibiotics initially, and then once we identify, we can go ahead and hone down into specific antibiotic ranges. We can go ahead and do rapid administration, 30 mLs per kilogram for crystalloids, hypotension, or lactate above 4. Lactate, get used to seeing that one. No, it's normal ranges, please. And apply vasopressors if MAP is below 65 or systolic below 90, depending on who your doctor is. This, unfortunately, is a nasty infection. Meningococcemia is what that one's called. Anyway, we're going to monitor for respiratory failure, ARDS, DIC, AKI, also known as acute kidney injury, liver failure in elevated LFTs, AST and ALT specifically, anoxic encephalopathy, GI bleeds, MIs, and multi-organ dysfunction or failure. Big deal. Treat early, treat fast, treat often. While we're resuscitating, what are we looking for? We're looking for some changes. We're looking for serum lactates, normal, 2 to 2.5, above 4, big problem. Okay, lactate's a big deal. Base deficit, -2 to 2. We're looking at significant greater than 6, AVGs, and potentially use of bicarb to get our balance back into place. We're going to go into a state of metabolic acidosis here. Secondary respiratory acidosis, potentially if we begin to stop breathing, but we're talking severely late stage here. But initially, metabolic acidosis, and your body's going to try and compensate by increasing bicarb. Okay, well, that's great if it can, but if it can't, we may have to do it for you in the form of a bicarb drip, or we may have to do it for you in the form of a bicarb push. It just really depends on what your doc wants to do. Surviving sepsis, what are we going to try and do? Okay, here's our first 6 hours, and I strongly recommend you learn these. CVP, 8 to 12, MAP above 65, urine output greater than 0.5 milligrams per kilogram per hour. SCVO2, 70% or greater, and then we have a mixed gas of 65 or greater. Treatment options, crystalloid, this one, no this. 30 mLs per kilogram, vasopressors. First line, levofed, vasopressin. I don't see angiotensin II very much anymore. It is a potent vasoconstrictor, but the problem is it's incredibly expensive, and I have not seen it in a while, pretty much since the start of COVID. And then we step into the realms of, dopamine, neosynephrine, and epinephrine. Broad spectrum antibiotics, secondary pressors, corticosteroids to decrease inflammation and swelling the tissues, causing impaired perfusion further, and then potentially blood products. Yeehaw. There's a lot of other stuff coming down the line. I actually love end-tidal CO2, PaCO2 monitoring, direct access in the ET tube. I love sublingual CO2 options, but they're not concrete yet, or if they are, we don't see them in any hospitals locally. Percutaneous oxygenation is a big one. I love what they're doing there. I won't talk on it too much because I don't know extensively about it. But essentially, we're looking at alternative means of getting fluid measured in the body and into the body, and we're looking at alternative means of oxygenating tissues. But there's a lot to go before that happens. Yeah, old school monitoring. Delayed cap refill, that's huge. 2 seconds or less is normal. Greater than 4.5 is huge. Temp core of greater than 7 degrees is huge. And limb worm differential, huge. We do have what's called the infrared spectroscopy, or NIRS. It can be used with pulseless or hypothermic patients, and essentially what it does is it looks at oxygenation directly in the tissue that you are observing. Typically, you put this on a peripheral extremity to observe how much tissue or how much oxygen is available in the tissue. And it actually supposedly can be used to actually oxygenate too. I have not seen this. I don't know too much about it, but I'm aware of it. DIC, disseminated intravascular coagulation. What happens is your body's been affected for a while. We've been impacting our liver and spleen, among other things, and we are now attacking our ability to clot or form clots, or take clots apart. Secondary to fibrinolysis and depletion of platelets and clotting factors. That's exactly it. We clot, hyperclot, and then we bleed everywhere. It's great. Occurs with trauma, sepsis, severe disease, activation of clotting cascade. Patients are high risk for hemorrhage, very high risk, and they will bleed from everywhere. It's almost like you gave them a fibrinolytic, but you didn't. Lab values, PT, PTT, INR, fibrinogen, fibrin degradation products, and this one, I love it, D-dimers. You must know these for DIC, please. Causes: decreased production of thrombocytes, or excuse me, I apologize, we moved on to thrombocytopenia. Thrombocytopenia, decreased thrombocyte production. We've used them all up. Maybe you have increased destruction. In the case of what we talked about previously, balloon pumps really like these little guys. They're quite tasty little snacks. Splenic sequestration or damage, and platelet dilution. Heparin-induced thrombocytopenia, we have two types, and you should know these. Non-immune mediated, common self-resolving. Don't worry about it, not a problem. The one we're worried about, type 2. We have an immune response. It's pretty rare, but has a very high mortality rate. So we call it HIT. Platelet count below 50,000, okay, or a 50% reduction from baseline. So if it was 100 and now I'm at 500,000, that's a problem. And then what ends up happening is you have a full-blown response where your thrombocytopenia can have the inability to clot. So when you have the inability to clot or have a low platelet count, you begin to bleed from places you would not otherwise bleed. Big deal. Anemia. A lot of us walk around with anemia every day, but there is different kinds. Really, most anemias fall into the iron deficiency category. Trauma, inflammation, surgery, GI bleeds, and those are most true common causes. Iron deficiency is the most common of them. Be just aware of that. There is other kinds of like anemia, but the one we're most concerned about is just basic anemia, iron deficiency. I'm not going to discuss aplastic anemia too much in depth. It's something you've probably already gone over at this point in pathophys, but I want to build on this. You will actually see some patients so anemic they have a low hemoglobin, decreased iron carrying capacity. You'll actually see them get iron sucrose and maybe some packed red blood cells. It can get that severe. So, fun facts. It was a quick lecture. Thanks for tuning in and staying with me tonight. I hope you guys got something out of this recording. If you have any questions, always feel free to ask. You guys take care and have a good evening.